This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host. And today I'm excited to share my conversation with Dr. Brian Greer, where we discuss his paper, Management of Concussion Symptoms Utilizing Mechanical Diagnosis and Therapy, a case series, published in the Journal of Manual and Manipulative Therapy in July 2024. In our discussion, Dr. Greer describes the 3 patient cases featured in the paper, explains how to assess these patients and exclude concussion as a diagnosis, shares insights on the directional preference of the cases and the progression of forces used in treatment, discusses the various symptoms presented by these patients such as light sensitivity, temporal pain, dizziness, and headache, and how they were resolved by reducing the derangement. Dr. Greer is a McKenzie Diplomat physical therapist who opened his McKenzie Certified clinic in Connecticut in 2021. He is also the author of a 2022 case report titled Flexion Directional Preference in a Patient with Low Back Pain, Utilizing Mechanical Diagnosis and Therapy, a Case Report, which we discuss in detail in episode 76 of our podcast, so feel free to check it out if you miss it. If you find our conversation informative, please subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share this episode with colleagues who might benefit from these insights. Thank you for tuning in, and let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like
Welcome to Urban Polling. Discover the Activator program and polls for rehab and balance.
Sarah Health, and here is a special offer from our listeners. Visit sarahealth.com/ptprotalk for a 90-day free trial. That's sarahealth.com/ptprotalk. Make RTM simple. Choose Sarah Health. That's sarahealth.com/ptprotalk. Hi Brian, welcome back to PT Pro Talk. How are you today?
I'm good, Mariana. Thanks for having me back.
Awesome. So I was super excited to chat with you about concussions after the Congress, the paper that you all presented. So let's just get started talking a little bit about yourself and your background.
For sure. So I'm a McKenzie Diplomat. I have a sports medicine practice in Glastonbury, Connecticut. And recently had a couple interesting cases that have been presented to me to write up, and that's what we were able to do here with Dave Pleva and Jared Hansen with these patients, these athletes that were suspected concussions and didn't turn out to be that way. So I was happy that they called on me to help them write this up, as I do have a bit of a passion for writing, especially with the McKenzie method, and I think it brought up some interesting points here that we're going to talk about today.
Yes. So like the paper that you just published in July 2024, right, is the Management of Concussion Symptoms Utilizing Mechanical Diagnosis and Therapy, a case series, published in the Journal of Manual and Manipulative Therapy early in this July. So like the case series describes the use of MDT to classify and treat 3 patients with suspected concussion-like symptoms, right? So could you just briefly describe these 3 patients' cases for us?
Yeah, for sure. So we had 3 different athletes. One of them, the first case was a 15-year-old wrestler who struck his forehead twice and started having symptoms after the second strike. There was headaches, dizziness, blurred vision. He was walking slower and presented after that head strike, and the mechanism of injury caused the clinician to suspect that there could be concussion. Similar with the next case of a 16-year-old who was sliding headfirst into a base playing softball and struck her chin. So that same type of impact, coming up with jaw pain afterwards, TMJ, and a headache, could definitely suspect that a concussion was present, taken out of the game at the time. And then the third case was a football player who was blindsided, fell backwards, said that he blacked out briefly, had dizziness. Definitely a case where they come off the field and the first thing that you're thinking is concussion.
And like on these cases, I think my first question is, how do I identify if it is coming from the cervical, if it is a concussion? So how do you rule out like red flags and anything more serious that could be as a result of a concussion?
So I think that the McKenzie system definitely has the appropriate red flag ruling out built into it, which is great in any case, but especially when somebody comes in after they hit their head. Going through the form and knowing what your red flag questions are, a lot of it pertains to medical history, but in this case, the mechanism of injury and what their symptoms are afterwards, knowing what the dizziness is associated with, if anything, if they have any like difficulty with speech, or they have any other signs that would indicate an immediate referral to the emergency room. It all comes into play with understanding that full history of how it happened and how they're presenting. And what we love about what Jared did here was he treated these patients just like they were any other patient coming in, without having seen a doctor first, where you need to make sure that they're safe to treat first. And he did just that, not assuming just based on the mechanism of injury that they A, had a concussion, or B, needed to be sent to the hospital for imaging or anything like that.
Yeah. And I think a lot of times, like as I was reading the paper, the symptoms are very similar, and it could be kind of tricky to differentiate. And I think on that first case, the symptoms are blurred vision and nausea, right? So
Yep.
When you see that, I feel like sometimes, if it's something more serious, you're kind of scared of like start, treating or thinking that could be like a derangement.
Mm-hmm.
So I think that was something that got my attention on that first case.
Well, the nice thing is that when we're talking about patients that come in after they've hit their head and you're suspecting that a concussion could be present, when it comes to those McKenzie classifications, they really could only be serious pathology, recovering trauma, or derangement if they fit that type of typical concussion presentation. So the awesome thing about that is if you use the system appropriately and you funnel them in the appropriate classification, then you follow it through just like you would with a patient coming in with neck pain to find out what they are first. And that leads you to the appropriate treatment, even if that is referring them out to a specialist, sending them to get immediate medical attention, or treating them like a derangement like we had in these cases.
Yeah. And like any other tests that you recommend like people doing to, other than like the normal ones that we do in McKenzie, like any cranial nerve function, like the eye tracking? I saw the few that you describe on the paper.
Yeah, and I think on a case-by-case basis, it's important to incorporate some of those other tests for, neurofunction, and make sure that even cognitively they're appropriate to treat in the moment. And that all contributes to ruling out those serious pathologies. But in these cases, when the patients came in and they were dizzy, or they were having some difficulty walking even, I would always want to make sure that you're doing some of that, even a simple neuro screen, to be a part of your overall investigation into what they've got going on. And that's always a good thing to be able to fall back on. Even something like the impact scores that these athletes had gone through, in these cases, knowing that they were similar to their baseline scores gives us even more evidence towards, okay, maybe they don't fall into that trauma classification that a true concussion would be. More likely that there's a derangement present that we need to test for, especially seeing that they were safe to treat after the visual tracking and all of the neuro function was checked out.
Yeah, I think that was very interesting that they have that test before, so you could go back and check their baseline. So that's very helpful that you have their scars prior to the impact, right?
Yeah, and like we know about anything else really, and some of what the research shows about the validity of different special tests, and it's important to understand all of that because I think too often, especially a newer clinician or a more novice clinician, will rely too heavily on some of these tests and assume based on what the patient or the athlete comes in with that they must fall under that concussion because of the way that the injury happened or the fact that they're dizzy or maybe the result of this test. And we definitely don't take serious pathology testing lightly, but at the same time, any test that is performed with a patient, in especially a case like this, should be taken with a grain of salt as part of your overall assessment, because otherwise a lot of these derangements could be missed that we saw in these cases. And unfortunately, that could lead to improper diagnosis, keeping patients on the sidelines longer than they need to be, and and not getting the right treatment for them sooner.
Yeah. And then going to that case one, so the symptoms are mainly headache, right? Like at first had headache, dizziness, blurred vision, and nausea, but no neck symptoms per se or extremity symptoms. So it was mainly like the headache. Is that right?
Yeah, mostly the headache with that first one. And, that's where the importance of that movement exam and then the repeated movement assessment comes into play, because once Jared had looked at that person's cervical range of motion, definitely found that they were symptom free except for some stiffness with bilateral rotation and extension, even into that like second visit that he saw him in. So when you see things like that, it's often like the derangement that doesn't have the obvious symptoms that we see some patients come in with. You have to dig into that end range a little bit. You got to investigate other parts of the spine sometimes and see if something is hanging out in their thoracic spine that we might have missed. And in this case, Jared did a good job of making sure he thoroughly went through the cervical spine to, first of all, get rid of the headaches in that first encounter, but then progress him to the right loading strategy and going into cervical retraction with that overpressure to get the rest of that stiffness out.
So like the on the first case with the headache, he started treating just with retractions, right? That was the first strategy. And then?
Yeah, basically found good results with that retraction initially, added that overpressure. And when they came back in, the fact that they were still having some of that stiffness in extension, decided to progress to retraction with extension, and that ultimately cleared the symptoms out completely. The athlete remained symptom-free for the next 3 days and was able to return to sport.
Okay, so now my question is, so when you do retraction, you're thinking about flexion of the upper cervical, right? And then when you're doing extension, then you're thinking about if you look at the upper cervical, and then would be extension, right? So like, do you feel like the lower cervical could be involved? Or like, why, when you progress to extension, if you think that the symptoms are coming only from the upper cervical, right? Then you would progress on flexion. So that was I was like, okay, so is lower cervical involved? Like, what is the rationale behind that and why they respond with extension then?
Yeah, it's a good question. I think that's the beauty of this McKenzie method, is sometimes you do need to investigate a little bit further other parts of the spine, even if it's just within the cervical spine. But in this case, I think it was just the signs of a true derangement, where they are oftentimes variable. They don't always follow the rules anatomically of what is being loaded and where the symptoms are coming from exactly, like what vertebral segment is involved. In this case, I think that a lot of the majority of those headache symptoms being cleared with the upper cervical movement just led to Jared seeing, okay, what else is left over here that's causing symptoms? And sometimes we just see other segments involved, and in this case, involving that retraction extension to get to the lower cervical spine, probably just cleared out more of the neck that was involved from this impact injury, especially if the mechanism of injury is somewhat traumatic and it's not just like a postural limitation that's happening at one specific area. There could be a little bit more to what levels of the spine are involved here and more to look at. So that's where it's always good to be thorough and check on that end range cervical movement to see what's causing the lasting symptoms that are still here, even though we got the majority of them cleared out in the first visit.
So it was like the headache reduced and abolished only with the retraction, right? So like he just did extension to treat the stiffness on the neck, right? Is that right? Correct?
He was left with some basically lasting stiffness when he checked those baselines afterwards. And, that's, I think, what often happens when patients are better, but not completely better, or there's still some functional things that are difficult for them to do. And if the clinician is not thorough enough with exploring different force alternatives, different loading strategies, or in some cases recovering function, that's where I think you start to see those patients who come back after a couple months saying, hey, my symptoms are back, or they're 80% better and the clinician can't seem to get them past that hump. So always coming back to those baselines that you set or the movement assessment that you did on that first visit not only helps to find if there's still stiffness present that the patient wasn't necessarily feeling like the headaches that were the dominant symptom, but is there still some of the derangement that's not fully cleared out yet?
Okay. Before we go to case 2, anything else to add on case 1?
No, I just think that pointing at what Jared was able to do with that force progression, and even before going into extension, exploring what self-overpressure did, I think it's a good message for a lot of the people listening who are either new to McKenzie or wanting to get into it, is understanding not to jump and make big changes before you look at some small changes within the same movement that you're doing, adding force, changing maybe the loading strategy or the starting position. And in this case, I think you did a nice job of saying, we've kind of exhausted what force I would expect to help in retraction, and let's look at adding in the extension since there's still some extension stiffness there. So just cool to see how Jared's mind work in that clinical decision making.
Good. Okay, so now on case 2 that you briefly mentioned before, I think the main complaint was pain on both sides of the jaw and the TMJ, right? And headache.
Yes, and a headache. In this case, she was taken out of the game, and that's when Jared was able to take a look at her in this case.
And so then what was his first intervention?
So in this case, Jared had looked at sustaining some cervical retraction with self-overpressure and seeing what that more sustained pressure does compared to a repeated movement. Oftentimes, more favorable outcomes in the upper cervical spine, which is why Jared probably looked at that. But even anecdotally, I've seen a lot of cases with headaches that respond well to sustained postures like that. And what's interesting in this case is obviously this was an athlete who had just had a impact injury, headache to follow that, and responded well to a sustained position. I think a lot of the thought process with some patients who come into the clinic with headaches that maybe sit and have poor posture, working at a desk for a living and feeling headaches by the end of their workday, it's oftentimes that sustained opposite direction that their head is sitting in throughout the day that benefits so much from sustaining retraction for a while. So
Mm-hmm.
pretty cool to see that the benefits of that sustained position worked even in a more traumatic onset of the symptoms here.
Yeah, what I think was really interesting, like in the beginning, he did the posture change, and then the headache decrease, I think was like 7 to 8, then went to like 6, just correcting that posture. So that could be one other thing to consider if you have like maybe a change that could potentially lead him to think about sustaining, potentially. I don't know.
Yeah, seeing that, and then even just testing out on that first encounter and seeing what effect repetitive movements have on the symptoms, and if it's not giving you the effect that you would expect to see, or if you are following that traffic light guide, once again, changing to a sustained position is something that I think is often overlooked,
Mm-hmm.
because people might just go right to a different direction of movement. They might add force, which isn't necessarily wrong, but if you forget about the effects of a sustained position, especially in the upper cervical spine, you might miss the one that's going to make them better.
Mm-hmm. And what I think was also interesting that when the patient start performing the retractions, the repeated retractions, the bilateral temporal pain increased, but then the headache decreased, right, at the beginning. And then I think he repeated again, and again increased the temporal pain, but then decreased the headache after. So that's interesting. That
Yes, definitely interesting to see those mixed results. And I think that a lot of times when I see symptoms, some symptoms improve, some symptoms increase. Oftentimes that tells me that I'm in the right area, but something about it needs to change to see everything improve. And that's a perfect example of, you know, testing out that sustained position rather than just switching
mm-hmm.
entirely to a different direction. It's enough improvement to say we're doing something right here, but we need to make a small change to see full progress made.
Because then was when she sustained the retraction that then the temporal pain finally starts to decrease, right?
Right. Yeah. And you kind of see that all come together. And it's a true case of, she was moving in the right direction, but some of those symptoms just needed that increased hold, that end range to see it fully abolish. And, that's another one of those, a more novice clinician might get that person 80% better by just continuing to do repeated retraction and get kind of scratch their head about what they need to do to get back on the field completely symptom free, and could take a little bit longer. In this case, I think the fact that immediately recognizing what effect the direction of movement was having, but needing to change something about it, made all the difference in seeing that immediate relief, able to confirm a derangement was there, and knowing that this athlete was not a concussion and was going to be able to get back to the sport sooner.
Yeah, I think that's a great reminder for us to remember to use those sustained positions, and seeing that even like the jaw pain completely abolished, temporal pain, headache, and she had troubles opening her mouth, right? So I think that was all very interesting how everything got better. And if you wouldn't have assessed with McKenzie, right, you would miss that one. She would be probably suffering.
Absolutely. Yeah. And talk about a true sign of a derangement, right? Between the jaw and the headache and movement loss of the jaw. It's really cool to see that assessment and treatment like this could be performed right on the sideline, doing a posture change with the patient sitting on the bench out of the game that they're trying to get back into. It's really it's really opening up possibilities for more of that to happen in the athletic training world. I know that there's been other examples of this demonstrated by athletic trainers out there that are certified and diplomats of the McKenzie method. But every time you see a case of an athlete who's able to immediately abolish symptoms, it just gives us more indication that we need more of that present on the field. It could make all the difference in players potentially getting back into the same game that they would otherwise be sidelined for. And on top of that, getting back to the sport sooner in general versus somebody who might be misdiagnosed as a concussion out for the rest of the season. All these unfortunate missed opportunities that might have happened because there was somebody with a cervical derangement that got told that they have a concussion and couldn't play for the rest of the season. That can change careers, lives. So it's really cool to see the ripple effect of simple movements, posture changes, giving the clinician insight as to what's truly going on there.
Yeah, and it's just such a great tool that you could use in that case to help so many people that otherwise would miss. And now jumping to case 3. So we had some different symptoms here. Do you want to talk a little bit about it?
Yeah, so it was good to see the difference in this case where, the athlete came into the clinic a little bit of time after, the next day of when the onset began, having some more of those true concussion-like symptoms where there was headaches, they were sensitive to the light, and with that mechanism of injury that you see a lot in football of getting blindside hit, possibly hitting their head on the turf, blacking out, definitely it would put the clinician in more of a position to say, I think this could be a concussion. I'm wondering what the best intervention is for this person immediately. But once again, showing the built-in safety mechanisms of McKenzie here, where just start to move their neck around, see things change. It's a lot to be said about trying a mechanical assessment with these athletes when it's safe. You're always going to rule out that they are safe to move, make sure that they don't have something more serious going on that would stop your assessment there. So really cool to see the changes that happened in this case as they played out.
Yeah, and I think one thing that got my attention was the short duration increase in headache pain level with the horizontal tracking. So that would be, that's interesting, the symptoms and the light sensitivity as well.
Right. Once again, just showing the variability that derangements present with. It's really no different than the lumbar derangement that has, pain in the knee and no pain in the lower back, or tingling in the big toe. I mean, there could be such a variety of symptoms that come from the same issue. And in this case, that little inkling of cervical pain that was less of a concern than the headaches and the sensitivity to the light and the dizziness, it's enough of a clue to say, let's check out the cervical spine. But in any case, you can't forget to take a look at the cervical spine, even if they didn't report that cervical pain, because that could be the last thing that's on the athlete's mind when they're dizzy, they are sensitive to light, or they blacked out when they got hit.
And in this case, he also had the loss of motion, right? So it was like associated with the cervical symptoms, like the mechanical symptoms, extension, retraction, the rotation, lateral flexion. So he had some other mechanical symptoms as well.
Yeah, and I think it's interesting too to incorporate the possibility of some of those other, not necessarily McKenzie classifications, but when a patient comes into the PT clinic and they've got dizziness and they've hit their head, and even if they've been ruled out from a concussion, the clinician might be thinking something along the lines of like a cervicogenic dizziness, which is in largely a diagnosis of exclusion when you've ruled out other causes of dizziness and you've maybe looked at vestibular contributions and all of those are negative. And we look at how their neck moves and if they have limitations in their neck movement or some types of positive cervical signs, then you can call them that cervicogenic dizziness. But anybody who presents like that could also be a derangement if that's not the way that your mind is thinking. So in this case, it's good for any clinician to consider that once you found out that their neck is the source of the symptoms, just because they hit their head and they have dizziness doesn't mean that they necessarily need to be brought through like cervical stabilization and VOR training or other things to help with their balance and their dizziness. If you forget to look at the effects of repeated movements on those cervical symptoms and everything else, you could be wasting a lot of time. You could be missing the fact that they're a derangement, and all of those things could get better, like they did in this case, if you find their directional preference and move them enough that way.
And that on that case 3, so what was the intervention that he used?
So initially found that cervical retraction was helpful for some of those initial symptoms, and similar to the other cases where overpressure had to be added to see more change, but pretty quickly went eventually into that cervical retraction with extension and abolished that stiffness, got full extension range of motion. So this was another case where you just saw that there was still a loss of extension. And in this case also was lacking in full lateral flexion range of motion on day 2, and decided to look at incorporating extension, knowing that retraction had helped with initial symptoms, but hadn't completely cleared out all of the limitations that were present.
Including the light sensitivity. I think that's crazy.
Yeah, right. It's in this case, you can move that patient back into the brighter room if you needed to when he came in on that first visit. But yeah, literally needing to change the room that he was in when he came in because it was too bright. It's pretty amazing to see the power of some of these approaches. If it's found immediately, you could see immediate changes in their presentation, even in sensitivity to light and other types of symptoms that you wouldn't expect.
Yes. And like, let's say, for example, if the light sensitivity did not improve, do you think it could be like a mix of like concussion and derangement? Or like these cases, we know that they all improved, so the derangement is confirmed. But do you think it could be like a mix of presentations?
It's an interesting question. And I think that there's always that possibility that when a patient has something that's confirmed, like a concussion, and they're a true concussion, that there's a possibility that there could be a derangement present somewhere. And just based on the amount of force that was applied to the neck to cause concussion, is there a good possibility that that person has a cervical derangement? For sure. But I think in those cases where along McKenzie classifications, you would only call them a recovering trauma, because that's what you need to treat to treat the concussion appropriately. And you're not going to be bringing them into like end range cervical retraction and extension if it's not appropriate. Oftentimes I find that even treating people with the other category, by the time you appropriately manage them, you see that there's still something underlying, and that's where repeated movements and sustained positions help those maybe lingering derangements that are present as a result. But typically, in terms of McKenzie classifications, we don't like to have like 2 on the table, and eventually if it's a provisional classification, you want to narrow that down to 1 for appropriate treatment purposes. But I agree. I think there's a lot of cases where there could be something else underlying besides the primary classification that you're focusing on treating because it's the right thing to do.
And I know that we need a lot more studies, but like do you have any guesses on that? Like in percentage wise, I know it's really going to be really hard, but how often do you think that we could have those patients with concussion-like symptoms that could be derangements that we are missing?
Yeah, it's hard to say, right? I think
Yeah,
that, just based on what we know about concussions in general and true concussions, of course, where they're managed appropriately. I know there's still such a large percentage of that in varieties of sports, but it would be really interesting and important, I think, to test more of these patients for cervical derangements, because there's a good possibility that some of those more minor symptomatic events that athletes probably go through every day that might appear like a mild concussion. I think especially in those cases, it's important to see if there's something else going on that could be fixed sooner rather than later.
yeah, that would be a good question probably for Jared.
Yes.
He's probably there seeing a lot more patients
Yeah.
in the
Hopefully Jared
field.
can collect some more data for us here and we can get more awesome results from what he's doing.
Yes, very interesting. Anything else on case 3?
No, I think in that case, it supports what happened in the other cases where all 3 of them were able to return to varsity level sport in 2 or 3 sessions. None had a return of symptoms with their return to play. So again, it's especially when you're dealing with concussion and all of that is monitored so closely of if they're having symptoms returning or what happens when they return to play. Knowing that they're safe to return, first of all, because you've confirmed that they have a derangement, but also knowing what they need to do if those symptoms were to come back, even with something else besides the sport that they're playing. It's such a powerful thing for the clinician and the athlete alike to be able to utilize. Going back to that repeated movement as soon as you feel an inkling of those symptoms. And, on top of that, doing your repeated movement as part of your warm-ups in sport, knowing that it's just setting your neck up for preventing that injury from coming back on. It's just really powerful stuff.
Yeah, it's crazy how they can return to sport so quickly. And on top of that, being able to manage their symptoms if they come back. So yeah, that's great.
Definitely. And what we had talked about at the conference was that these principles can be applied to getting people back to other things, even if they're not athletes and they've hit their head. There's a lot of examples of this in the workplace where we have work-related injuries that are traumatic, in the military when there's head injuries and motor vehicle accidents. All these people getting back to those respective things or just back to their everyday lives that they might be significantly limited in. Those can be plenty of cases of misdiagnosed concussions as well. And especially for the people that have chronic pain and it's due from one of these events like a car accident, if we can avoid getting patients to that point because they were misdiagnosed and because they stayed away from activity that they would be doing, just knowing that ripple effect of catching the right classification early and giving them what they need before it turns into a chronic pain situation or before they're out of work for months or years or whatever it may be. It's really important to get the right classification early.
Yeah, and I think the paper was so interesting that brought all these different symptoms that sometimes we don't even think that, could be a symptom of derangement because we are not used to seeing them or thinking that they could be a derangement. So I thought that was very interesting, like all the just bring to our attention that we could have those symptoms, and it's worth it to do a mechanical assessment to see if they could be coming from the cervical or from the spine.
Definitely. Yeah. In most cases, it doesn't take very long. It can be incorporated into one session or part of a session where you're just making sure that they don't have something that's going to get better a lot faster than if you were to miss it.
Yes. We need more people trying MDT and let us know the percentage and the results. I would be very curious to see more numbers, right?
I agree.
Brian, any other takeaways from the paper that you would like to share?
I think like you mentioned, it definitely shows the importance of more research in this area specifically, but just other ways of thinking outside the box with mechanical diagnosis and therapy. It just shows that it's one example of how it can be applied in settings that are not typical. It's kind of proof that more medical attention could be avoided when it's not necessary. So in that way, I think using it in the emergency rooms where people came in after they hit their head, getting that quick mechanical assessment to avoid more imaging or unnecessary treatment in the ER, it can save people a lot of time. It can save healthcare dollars. But just getting this out there to more athletic trainers too, and seeing its use on the sidelines or in the athletic training room, we can help out a lot of more varsity teams that might be missing some of their star players because they're on the sideline due to injury. But I think overall, just changing the way that we view concussion screening and hopefully someday being able to normalize this as part of the concussion screening process, make it more of that protocol where everybody gets a mechanical assessment if they're appropriate for it. And if red flags have been ruled out, that being part of the mechanical assessment, it just would be worth it for everybody's sake in a concussion situation.
Yeah, absolutely. And if people want to research more or read more about the topic, do you have any recommendations?
I think that in general, just it's important to look at the research for concussion that's out there currently, because it's not something that I think should be overlooked. One thing that we definitely didn't want to underplay the importance of appropriately treating a true concussion. So staying up to date with the current research in concussion and physical therapy is super important for those cases where you classify them as a true recovering trauma. But otherwise, staying up to date on the McKenzie website and seeing the research that comes through there. But I'd always be happy to chat with anybody who wants to reach out and learn more about the paper, get copies of the article. They can contact me via email.
Awesome. And what would be a good way to contact you? You said your email.
For sure. Email would probably be the easiest way, and I can give you that information to post afterwards.
Okay, I can add that to the show notes. Anything else, Brian, to add?
No, Mariana, I appreciated you having me on today and talking about this, and just looking forward to seeing what else comes down the pipeline with concussion research and the McKenzie method.
Yeah, it's just such an interesting, different topic. I was like, I have to bring him here to talk about concussion because that was so different and got my attention. So I'm glad to share that and hopefully, bring the topic to more people so they can, open their minds and see new things coming. So thank you so much for taking the time and share with us a little bit about that paper.
My pleasure. Thank you so much for having me.